Welcome to the Explainer. Today, we're diving headfirst into a high-yield pharmacology bootcamp. We're going to distill some of the absolute densest drug classes down for rapid retention. Look, if you want to conquer pharmacology, you've got to understand the underlying mechanisms, you need to memorize those high-yield side effects, and you have to know your absolute drugs of choice inside and out. So let's get focused and jump right in.
We've got a massive amount of information to cover today, so we're going to chunk this into 5 distinct clinical sections. We'll start with antihistamines, allergies, and beyond, then move into skeletal muscle relaxants, tackle local anesthetics and numbing agents, look at the GI tract for ulcers and emesis, and finally wrap up with GI motility and bowels.
Okay, let's kick things off with Section 1, antihistamines, allergies, and beyond. We'll be comparing first versus second-generation H1 receptor antagonists.
So, the absolute crucial dividing line here is the blood-brain barrier. First-generation drugs, they cross right through it. And because they cross into the central nervous system, they cause CNS depression, which means you're going to see strong anticholinergic activity, like severe dry mouth and urinary retention, right alongside marked sedation. Second-generation drugs, on the other hand, stay strictly peripheral. They selectively block H1 receptors outside the CNS, meaning they cause minimal to no sedation. This single difference basically dictates exactly how and when we use these drugs clinically.
Looking at the first-generation agents, you'll see they're incredibly versatile. Drugs like chlorphenamine and diphenhydramine are classic for treating basic allergic reactions, while promethazine is great for motion sickness. But, they carry a heavy burden: marked sedation, confusion, and those severe anticholinergic side effects we just talked about. Hydroxyzine is another interesting one, pulling double duty for pruritus and anxiety. And then you have meclizine, which targets vestibular pathways, making it highly effective for vertigo and Meniere's disease.
Now, what's really fascinating is the modern shift in allergy treatment, driven entirely by the improved side effect profiles of the second generation. Agents like cetirizine, loratadine, desloratadine, and fexofenadine treat the exact same allergic symptoms, things like allergic rhinitis and chronic urticaria, but with negligible central nervous system penetration. Fexofenadine, for instance, has virtually no sedative effect at all, while cetirizine and its active isomer levocetirizine might cause only very mild drowsiness in a few patients. It's a total game changer.
Let's lock in these clinical pearls, all right? If a patient has allergic rhinitis, you reach for cetirizine, loratadine, or fexofenadine. But if they're complaining of motion sickness, you've got to pivot back to those first-generation agents like promethazine, dimenhydrinate, or meclizine. And for allergic conjunctivitis, keep your eyes on topical agents like olopatadine and azolastine. Moving right along to Section 2, skeletal muscle relaxants. We're looking at relieving spasm, stiffness, and tone.
To really understand these agents, we need to divide them geographically. Peripherally acting relaxants work right at the neuromuscular junction or directly on the muscle fiber itself. Centrally acting relaxants, conversely, do all their work up in the spinal cord and subcortical areas to inhibit reflexes.
In the surgical realm, we rely on the heavy hitters. Non-depolarizing blockers, your vecuronium, pancuronium, atracurium, and rocuronium, act as competitive antagonists during general anesthesia. Contrast that with succinylcholine, which is the lone depolarizing blocker used for rapid sequence intubation. It actually causes persistent depolarization that leads to paralysis. Finally, there's dantrolene, which is super unique because it's a direct-acting relaxant that blocks calcium release from the sarcoplasmic reticulum by acting on rhinodine receptors.
Now, contrast those surgical paralyzers with our central agents. Baclofen, which is a selective GABA-B agonist, and tizanidine, an alpha-2 agonist, are absolutely crucial for managing the severe, rigid muscle spasticity we see in conditions like multiple sclerosis. We also use diazepam, cyclobenzaprine, methocarbamol, and chlorzoxazone to relieve painful acute spasms. The big shared catch across all these centrally acting drugs: intense sedation and drowsiness. You're definitely not driving after taking these.
Lock these imperative summary points in your memory for sure. Dantrolene is the absolute drug of choice for a life-threatening condition called malignant hyperthermia, but you have to monitor for its major adverse effect, hepatotoxicity. Succinylcholine, while amazing for intubation, can actually trigger that very same malignant hyperthermia, as well as dangerous hyperkalemia. Also keep in mind that diazepam is the specific muscle relaxant utilized in cases of tetanus.
Next up, Section 3. Local anesthetics are numbing agents. We'll be looking at the ester and amide classifications.
So all local anesthetics share a common mechanism. They block voltage-gated sodium channels and nerve membranes to prevent action potentials. But the major clinical dividing line is their structure. You have the ester group, which is notably much more likely to cause allergic reactions because they break down into a metabolite called PABA. Then you have the amide group, which has a generally safer allergic profile and includes our most trusted daily agents.
Across the spectrum of amides, lidocaine is your standard go-to for infiltration anesthesia, while mepivacaine and prilocaine offer solid alternatives. Bupivacaine gives a really potent, long-acting block for spinal anesthesia, but beware, it carries high cardiotoxicity, which often makes ropivacaine a safer choice. On the ester side, alongside procaine and tetracaine, benzocaine is great for surface mucous membranes, though it can cause methemoglobinemia. And cocaine is incredibly unique here. It's the only local anesthetic that acts as a vasoconstrictor by inhibiting the reuptake of norepinephrine.
Here are your high-yield anesthetic takeaways. First, lidocaine actually pulls double duty. It's not just a numbing agent, it's also a class IB antiarrhythmic drug. Second, local anesthetics require an alkaline pH to work effectively. That means if a patient has an infection, the surrounding tissue becomes acidic, drastically reducing the drug's numbing effect. And finally, we often add adrenaline to these anesthetics to vasoconstrict the area, prolong the drug's action, and reduce bleeding.
Let's shift gears now to Section 4, the GI tract, focusing on ulcers and emesis. We're talking about managing peptic ulcer disease and nausea.
Before we look at the drugs, we've got to define peptic ulcer disease. PUD is a fundamental breakdown in the gastric or duodenal mucosa. This imbalance is primarily driven by Helicobacter pylori, which is a crafty bacteria that produces urease to survive stomach acid, or by the use of NSAIDs. NSAIDs are notorious here because they inhibit COX enzymes, which completely stops the synthesis of the prostaglandins that normally protect our gastric mucosa. When H. pylori is the culprit, we can't just lower the acid, we literally have to kill the bug. The gold standard of care is this precise triple therapy sequence. A proton pump inhibitor like omeprazole to drastically suppress the acid environment, paired with 2 antibiotics, clarithromycin and either amoxicillin or metronidazole.
For the ulcers themselves, omeprazole irreversibly shuts down the acid pumps, while famotidine blocks H2 receptors, and antacids like aluminum and magnesium hydroxide quickly neutralize existing acid. Sucralfate forms a literal physical paste barrier over the ulcer, and misoprostol, which is a prostaglandin analog, is specifically used to prevent NSAID-induced ulcers. Now, for antiemetics, we intercept nausea signals at the chemoreceptor trigger zone. We use ondansetron to block 5-HT3 receptors, or dexamethasone as a powerful adjunct. Metoclopramide and domperidone block dopamine D2 receptors, though with metoclopramide you really have to watch out for extrapyramidal side effects, which are severe, uncontrollable muscle movements. Lastly, we have aprepitant to block NK1 receptors.
Remember these critical capstones for GI. Endoscopy is the gold standard for PUD diagnosis, though the urea breath test works incredibly well for sniffing out H. pylori. For antiemetics, ondansetron is your absolute first line for chemotherapy-induced vomiting because it has minimal sedative effects. And scopolamine, an antimuscarinic available as a convenient transdermal patch, is the undisputed champion for preventing motion sickness.
For our final section, we'll tackle the extremes of bowel motility by analyzing antidiarrheals, laxatives, and purgatives.
While oral rehydration is always the mandatory first-line treatment for diarrhea to prevent dangerous dehydration, we have a vast pharmacological backup. We use opioids like loperamide and diphenoxylate, which conveniently don't cross the blood-brain barrier, to halt acute motility. Absorbents like chyalin and pectin bind up toxins, probiotics help restore gut flora, and antibiotics like ciprofloxacin target specific bacterial causes. We also use bismuth, an anti-secretory that can harmlessly cause a rather alarming black tongue and black stool, and racecadotril, which is a fascinating enkephalinase inhibitor that reduces intestinal secretion without paralyzing the bowel's motility at all.
Conversely, for constipation, we categorize our laxatives by their distinct mechanisms. Isfigula is a bulk-forming agent and is considered the safest class. Osmotics like lactulose, milk of magnesia, and peach draw water directly into the lumen. Lactulose is also uniquely used for hepatic encephalopathy to help clear toxic ammonia from the body. Then we have stimulants like senna and bisacodyl. These directly increase motility, but should definitely be avoided for long-term use due to dependence risks. And note that senna can cause a yellowish-brown discoloration of urine. Finally, softeners like docosate and lubricants like liquid paraffin simply help ease transit. Mastering these high-yield facts, mechanisms, and side effects is exactly how you conquer pharmacology. Remember our high-yield challenge: malignant hyperthermia. The answer is dantrolene. But as we look at how broadly some of these drugs act, like first-generation antihistamines flooding the entire central nervous system just to treat a simple sneeze, it begs a massive question for the future of medicine. How close are we to developing perfectly targeted drugs that fix the localized problem without causing a cascade of systemic side effects? Keep reviewing these pathways, and I'll see you in the next explainer.